Okay.
Not seeing you yet.
Yep. I'm going to see if I can get it to share first.
Now we got you.
Do you see the slides?
Yep.
Great.
Yep.
So I appreciate it, guys. We're going to go over some of the radiation therapy strategies that we use for skull-based malignancies, an invited review through the JNO. Most of what I want to cover and sort of in that mostly discussion format is just how do we choose the different techniques? What are the ramifications of different radiation techniques? And it's a lot of what we talk about in the paper is we kind of go through the different types of tumor histologies in different locations of the skull base and how we would choose between gamma knife, which is in the far left, IMRT, which is our more sophisticated radiation delivery technique, or IMPT, which is a charged particle or proton therapy. And nowadays, and Dr. Trifoletti can go through this in great detail too, we have carbon available in some of the European and Asian countries and should soon have carbon available in the United States. And so just to kind of hammer home the differences in how we choose these, this is sort of a tumor in the skull base, upper cervical spine, kind of demonstrating how we go about from a radiation perspective, treating a tumor that involves a number of skull base structures, head and neck structures. And you see that with IMRT, a lot of the radiation treatment in lower doses kind of get spread or sprayed throughout the body. With proton-based therapy, that dose distribution is much tighter. That low dose is spared throughout that part of the body. And just as a brief kind of tutorial, it's pictured here on the right that the physical difference between a proton therapy and a photon therapy is that protons, based on our image, sort of our energy, stops in the body, allowing us to spread that out, treat the tumor, but things distant to the tumor don't get treated, as opposed to an X-ray or photon-based IMRT approach, which tries to put our focal point in the tumor, but spreads out both before and after the tumor entrance and exit dose. This is what contributes, this orange here and here is what contributes to this low dose spray that you see throughout an IMRT plan. And so here we'll sort of open it up because I think the key that we wanted to get across to the reader as well as anyone listening is that these skull-based tumors are complex. They're complicated tumor histologies that most of our data is based on small series, retrospective series, and really just expert opinion. There are many different histologies that can occur in this location, and really a multidisciplinary team with a very skilled neurosurgeon as well as a neuroradiologist adept at reading and understanding how invasive a tumor is and where it is sort of invading, as well as a radiation oncologist that treats these locations often, is important because each one of us can sort of detail how would we treat, in what way, using what modality, and a lot of that depends on the surgical opinion and what the surgeon tells us during surgery. So super important that we work together as a team. And so in our paper, we sort of go through all of these cases in multiple different tumor histologies, the data that is there for each different tumor histology and how radiation can be used in those different histologies. So we use a couple of different cases, and I just used a couple of really interesting cases here that both with PET imaging and MRI, really difficult locations within that skull base, how we can utilize surgery and radiation in those areas. So with that, I kind of would want to open up to any questions you guys have or any additional comments from Dr. Gomez or Trifoletti.
Dr. Gomez, Dr. Trifoletti, any additions before we jump in?
I think Josh, Dr. Palmer was trying to point out very clearly the importance of the multidisciplinary approach want to say that we review all these cases that we treat at our institutions weekly on our skull-based tumor board, where there's the surgeons, the radiation oncologists, and the medical oncologists discussing the cases. Then is decided, obviously, the treatment approach for these rare malignancies. And in our department, the radiation oncology department, we also do weekly peer review of the contours for radiation, as well as of the treatment plans with all our colleagues to obviously get the best plan and approach regarding radiation therapy in these difficult locations.
Yeah, I think obviously these are incredibly complex lesions, and we've made a lot of progress surgically from the surgical end of things in the recent future. And then obviously the different options of stereotactic radiosurgery and radiation in general, targeted radiation, have given us a lot of hope for treating, very, very complex things. What are you guys using? Dr. Palmer, what's your kind of modality of choice, or what are you limited to based on your institution?
So in our institution, perfect question. So
yeah,
we do have a gamma knife machine. We have the Icon, which allows for both frame and frameless treatment. The other modalities that we have are LINAC-based radiosurgery techniques that can mimic a cyberknife. We don't have a cyberknife, but we have very similar treatment techniques that can deliver a 5-fraction radiosurgery. And we commonly, for instance, like the patient whose imaging you can see on the screen, we also deliver a long-term fractionated therapy, or like an FSRT, over a 6-week time period for a lot of the really complex large masses to gain local control. We don't have protons yet. Proton therapy, or our gantry, is being built currently. We'll likely have proton therapy open and available for patients in Central Ohio around late 2022, early 2023. And so we don't have proton therapy here, but for patients where that's deemed necessary, there are some skull-based malignancies where that's by far the best choice, like the chondrosarcomas is a good example. We do send them in the chordomas of the skull base to a proton center nearby. There are 2 in Ohio, one in Cincinnati, one in Cleveland.
Mm-hmm.
Just want to chime in here. Thank you, Dr. Palmer, for the rest of the team here. This is a pretty interesting paper. I just wanted to ask, I'm at Rutgers, and we've recently had a sort of a string of cases of paragangliomas. I've got a couple of them, and just want to get your thoughts on the optimal radiation strategies, just management paradigms, sort of the algorithmic thinking of it. What are your thoughts on that, just for, say, glomus jugulare, or, jugular tympanicum tumors and things like that?
That is a great question as well, because we struggle with this. I think a lot of it for us in terms of the management strategy depends a lot on the particular skull-based surgeon that sees the patient, because I think depending on this pattern of practice for the surgeon, some of these patients will get a debulking surgery.
Right.
While others won't, because we tend to see large glomus tumors, and there's a large component that obviously is not very resectable, as it's sort of, a lot of them will track down into the upper head and neck region. But for the most part, the last probably year or so of cases that we've had do get a debulking surgery for the component that is visible and in the ear through sort of a skull-based neurosurgical approach. Our role is really to treat the remainder of tumor, and for elderly individuals who can't get surgery, we would treat it intact. My general treatment strategy is, if I can do gamma knife radiosurgery, if it's not particularly close to the IAC nerves or on the brainstem, or if it's a relatively small tumor, less than 2 centimeters, I'd probably do a gamma knife radiosurgery. I've been doing quite a bit of the 5-fraction radiosurgery, just for the very large tumors that are in sort of the maxillary space down into the head and neck, going out into the brainstem, if that component has not been resected, or along the IAC, along 7 and 8 nerves, or on the cochlea. I'll do like a 5-fraction radiosurgery. What I've also found quite useful is we we now will image everyone, and this is a picture of what a dotatate scan looks like, the gallium-68 dotatate scan. The paragangliomas all light up, so they are all positive for when using gallium dotatate. So the last probably 6 or 7 of them that I've done after surgery to determine the difference between surgical bed and postoperative changes, which is always a bit challenging in the skull base and the actual tumor. I've actually seen that the tumor is better seen in some of our cases on the dotatate in the head and neck area, where the MRI, or at least the radiologist, the neuroradiologist, didn't realize the tumor went down that low, because it sort of falls into an area where some of the fat saturation, it just looks like normal tissue. And so the gallium dotatate outlines it quite nicely in the skull base. And so I've done sort of fractionated radiosurgery using the skull base MRI as well as the dotatate imaging to delineate the tumor. But obviously that's not an FDA approved indication and has to be sort of discussed on a individual patient.
Yeah, we use it here too as at Lennox, and I find it's very valuable.
Oh yeah.
And similarly, we'll do a multidisciplinary conference where consensus agreement is necessary for something like what you're describing. But obviously a big victory in terms of treating these kind of things is to have that study available. Something you brought up about debulking surgery. Obviously surgical approaches are always being pursued, and people are trying to get the safest maximum resection, or sometimes the not so safest. What do you think about current results with some of these advanced radiotherapy techniques versus surgery? Should we be debulking? Should we be going for a gross total? Should we just do a diagnostic procedure, or take tumor off the really important structures and then let radiation do what it does, because it's got such positive benefits in these regions?
So I can kind of give my interpretation of what I think is best, but obviously I'm open to everyone else's opinion. I think for a lot of the tumors, like the glomus tumors, like a potentially large tumor in the IAC or meningioma of the skull base that's benign, I think my approach has always been a somewhat minimal type of surgery if a diagnosis is in question, because our techniques with radiation are so successful for tumors that are not causing very significant symptoms like a brainstem compression that's leading to patients in coordination or falling, or for instance. But if it's, like, say, for a glomus tumor, I think there is some value if we do think that a decompression surgery can help a patient not be so dizzy, or with some of the pulsatile tinnitus that's really causing like difficult quality of life. I think those are useful for some patients, but if we do think that that's going to help with an immediate decompression type surgery for a symptom, but in my perspective, I think less is more for some of these tumors, especially in the skull base. And then radiation can quite well control the majority of the disease. I think that really hammering home that we don't do a great job of improving a significant symptom for these benign tumors, but we do a good job of controlling them. What do you guys think, Dr.?
Yeah, Dr. Gottman, Dr. Trivoletti.
I'll add that in my mind, there's two benefits. Now, I'm a radiation oncologist. I'm probably speaking to mostly neurosurgeons, so whatever. But in my mind, there's two components to surgery that radiation will never be able to provide. One is a pathologic diagnosis, and the second is immediate decompression. So the situation that you're describing is really unique because you're sort of assuming that you know what you're talking about anyway. For a patient with an undiagnosed, unpathologically diagnosed skull-based tumor, I think there's a clear benefit to surgery in that this tumor that we're looking at on the screen could be like 5 different things. Mm-hmm. It's not super clear, and sometimes that can be even treated with medical therapy and no radiotherapy. So depending on what it is. So I think that the pathologic diagnosis is important. And then the thing about decompression is that most of these patients are going to present with symptoms, and the potential benefit, symptomatic benefit of a decompressive surgery is very confusing to everybody. It's totally dependent on surgical approach and technique. and honestly, like frequently unpredictable for optic nerve decompression or cavernous sinus compression. And so those things, the multidisciplinary component is really very important here, because the benefit of a potential surgery is really dependent on what the surgeon is envisioning in their mind's eye, which they might not even know sometimes. So I just want to bring that up. And then, but for the purposes of what your question, which was sort of more like, is radiation alone appropriate if you know what's going on? I think so most of the time, but it really does depend on the diagnosis. I mean, for instance, in a patient if this was a chordoma, then a surgery would be very valuable, because we know as radiation oncologists, I'm thinking, well, the chordoma dose is 30% higher than the brainstem tolerance to radiation, and there's no way that that's going to be met here ever with any technique. So decompression on the brainstem is critical. If this is a meningioma, that's about half the radiation dose, and this is what I'm thinking in my head. So there's stuff that I think that a radiation oncologist is bringing to the table that's very obvious to me, because we do it all day long, but maybe less obvious to you guys, where you're thinking like, oh, well, a transsphenoidal approach is stupid. That's bananas. You'd have to do this super tent infra whatever. So this language, that the way you guys think about stuff is just different than the way we think about it. So it's interesting as a radiation oncologist to talk to non-radiation oncologists who are interested in radiation oncology, because there are components to radiation oncology that are sort of instinctually obvious because we deal in it so frequently. But anyway, that was rambling, but that'll be recorded on the internet forever.
Well, no, listen, I mean, I think I agree with you, and I'm not someone who's anti-surgery being a neurosurgeon. I think that we should push the limits of what we can do surgically at all times. But the truth is, in a lot of these patients, you're diagnosed with something that's pretty terrible to begin with, location-wise, surgical approach-wise, potential complication-wise. I don't want to be another negative in that, right? So if I can debulk you safely, comfortably, and have faith that my radiation oncologist and my whole team, my neuro-oncologist, my whole team can, not cause you any further harm than what is necessary, then I think that's a huge win. I mean, it's bad enough that the tumor is going to do what it does. And so that's kind of my view on those things. We do have a question from the audience. And you've alluded to this a little bit here, which is that, based on gene expression, so are there tumor types such as the ones reviewed in this paper that are going to really dictate radiation therapy or, primary medical therapy? And I find that the majority of these tumors don't respond that great to medical therapies, but I wanted to get your guys' opinions.
Yeah, I don't think we really do that. I mean, maybe I could make up some unique examples where we would, but the diagnosis, I think, plays a major driver, huge.
Yeah.
But gene, I mean, for a recurrent tumor, you might do some fancy gene expression panel and find, foundation 1 testing shows a part bin in some weird thing like that.
Yeah.
But I can't think of anything off the top of my head that's common.
No, for the most part, it's a tough pathology group or tough group of pathology. Yeah, go ahead, please.
100% right. But so there are some tumors that we cover in the paper, and I think it's always up for multi-D discussion, because some of these fall in the realm of what a head and neck medical oncologist would probably deem chemotherapies are quite helpful. There are some, especially for pediatric tumors, that can be in the skull base, like some of these Ewing sarcomas or osteosarcomas, where chemotherapy would likely be planned. A surgery would be a component of the local control, but chemotherapy is sort of a part of the standard of care. And then there are others, like a small cell neuroendocrine carcinoma of the sinonasal location, or sometimes some institutions, and I think ours is one of them, I have to get Dr. Gomez's input, but like a SNUC, some of these other head and neck sinonasal malignancies, if they are large, I think get discussed with our skull-based team. Some of these do get neoadjuvant chemotherapy to try to get a surgery that may be either slightly less morbid, or to see if there's a response before going for say an exenteration of the eye or orbit, or taking a huge part of the skull base out. I think that there's a few of these histologies that the pathology is extremely important, like Dr. Trifoletti mentioned, because the paradigm is just so different. So it is very important to kind of discuss the imaging and imaging characteristics with everybody, because there are differences in management based on the primary pathology. I think some of them are pretty clear, but that's not always that's something that every case I think should be a multi-D case.
Dr. Palmer, I noticed you have, sinonasal adenoid cystic carcinoma on here. It reminds me of a recent case we actually had here in which, we had a fairly large mass going through the ethmoids into the orbit, causing significant amount of ophthalmoplegia for the patient. And the question was, do we go for broke and potentially have to take the eye, or do we do subtotal and then manage with radiation therapy? What are your thoughts on the response? Any optimal choices in terms of radiation for this pathology?
Yeah, I mean, I think I've definitely seen some cases where chemotherapy does a pretty decent job of improving the way that the imaging appears after several cycles of induction chemotherapy. I think the adenoid cystics can respond. What do you think, Dr. Gomez?
Yeah, so I think I echo what Dr. Palmer and Dr. Trifoletti is saying. So there's these newer entities, especially in the sinonasal area, where we start to know that they can have some genetic abnormalities, some chromosomal abnormalities that can help to identify some potential targeted therapy or systemic therapy, or other entities like SNOX, where we know now that with better radiation techniques and all that, and we have better local control there, that these patients tend to fail distantly. So we start to evaluate that, and we start moving more into doing induction chemotherapy to try to obviously control the tumor, shrink it down. That can help us for our tumor volumes, and to potentially have safer radiation doses to the organs surrounding the tumor. For the adenoid cystic carcinoma, these tumors, they're not very sensitive to systemic therapies. There are some newer targeted therapies that are being on early clinical trials that looks promising. There is also some data that some of these adenocystic carcinomas can be related to certain types of HPV that can also prompt for the development of other systemic therapies. But again, the difficulty of these are so rare, especially at the skull base, and that it's hard to have a definitive consensus yet.
Yeah, and can I add that one way to think about it, maybe I'm making this up, so this is dangerous, but the anterior nasal cavity tumors, the olfactory groove tumors with mucosal ulceration, those are sort of different in my mind, because a biopsy is much easier. It could be done endonasally in an office, as opposed to a clival tumor. So, and likewise, an initial biopsy of an anterior sinonasal tumor has a lot of value, because those histologies are more likely to be treated non-operatively or with induction chemotherapy or stem cell transplant, or some weird stuff for some of these rare tumors. So most of my comments previously were regarding to anterior brainstem tumor, but just a quick comment.
I hope that helps. But basically, I think it's very kind of histology dependent, and we do see a lot of induction chemotherapy for some of the sinonasal malignancies these days, mostly just like he mentioned, for the concern that they will metastasize. I think you hope that they will respond at the local site, but that's sort of very difficult to know. There's not like huge studies to know, that these are all going to respond to an induction therapy technique. I think a lot of our medical oncologists, at least here, choose that type of strategy to gauge a response, see if it will help in terms of our management, both surgically and with radiation. But a lot of it is that sort of fear that these people, while we're doing all of this and delaying therapy from a systemic standpoint, would, they would met out or something. But these are just very difficult to anticipate sort of the true, you could just go with an upfront surgery and then give chemoradiation out back, but sort of just depends on your particular institution.
Yeah, SNOOC management varies very widely depending on center expertise. Initial surgery or induction chemo or, 2-stage surgeries and stuff, that can change things a lot.
Yeah,
absolutely. Well, guys, we're approaching the 30-minute mark, which is where we like to cut this short, keep people interested. You guys have done a great job on the paper, and I know I speak for Jason when I say thank you for contributing to the Journal of Neuro-Oncology with it. It's a valuable resource, and I think a tremendous effort, obviously, compiling all the the large review that it is, and giving people a place to go for the answers they may need or want to look up. This will be published on the YouTube, like I said, so we can share the link with your colleagues and friends and family. Appreciate your time and energy. And just as a plug, there's a Miami Brain Tumor Conference tonight with Mitch Berger talking about awake craniotomies that Dr. Nitesh Patel will be a contributing panelist to as well. So be sure to check that out on social media. And we look forward to having you guys back with your next publication. So thanks so much.
Thank
Thanks,
you
guys.
guys.
Thank you.
Have a good evening.
Take care.
Take care.